Her home medications prior to the second hospitalization included her lisinopril, nifedipine. She was taking aspirin, folic acid. She was on a statin. She was taking hydrochlorothiazide and some fish oil. In-hospital medications included aspirin. The statin was continued. She was on prednisolone and leucovorin as part of her chemotherapy regimen. She was also on IV sodium bicarb, also part of the chemotherapy regimen. And she had some PRN medications for pain and nausea. Previous imaging included a renal ultrasound, which was mostly unremarkable. A chest radiograph, mostly unremarkable. She had a prior echo as well, which showed a normal left ventricular function. And this was her MRI on her first initial presentation to the ER, this was when she was diagnosed with a brain mass. So to recap the timeline, she presented to the ER with just worsening neurological symptoms. She was found to have a frontal lobe mass with a midline shift. Shortly afterwards, she underwent a craniotomy. 13 days later, she was started on her first dose of chemotherapy, which she completed within 5 days or so. She was discharged shortly after. She was readmitted 20 days later for her second cycle of chemotherapy. On her second admission, she was prepped for the chemotherapy, same as she was for her first admission, bicarb, fluid, and she was starting on the second cycle of the chemotherapy. It was on the day after the start of the second cycle that her serum creatinine increased to 1.7 from a baseline under 1. And on the 22nd is when nephrology was consulted to the case. Her vitals and labs on the day of the second admission were mostly unremarkable. Her creatinine was 0.79. Liver function was okay. Electrolytes otherwise are okay. We're missing a phos. Vitals were good. Blood pressure 131/60. Good heart rate, no fever. Statting okay. The CBC, mild leukocytosis with a normal neutrophil component. This was the morning of cycle number 2. So this is when so it took about 2 days for her urine pH to get to goal with IV sodium bicarb. On the 20th is when she started the actual cycle number 2. And that morning, again, her lab's unremarkable. With a normal chemistry, uric acid 4.6, and the CBC most unremarkable. The day, so 24 hours within, 24 hours into her chemotherapy, her creatinine increased to 1.71. Electrolytes remain normal. Again, a leukocytosis, probably related to the chemo. And she was anemic with a hemoglobin 6.9, had received blood at this point. And we also had a UA at that time, which was mostly unremarkable, with the urine chemistries also unremarkable. vitals were okay. And this is when nephrology had seen her on the 22nd. At that point, her creatinine had jumped to 2.06. Electrolytes remained normal, and the white count had decreased slightly. Vitals were also unremarkable at that time.
Chris, did you guys check uric acid, phosphate?
So we had checked the uric acid was checked once. It was 4.6, and that was at the time of her chemo start. But there was no phosphate ordered in patient.
How about LDH?
No LDH either.
Ay, ay, ay.
Any thoughts on what may be causing the worsening renal function?
I'm seeing nothing. Come here.
A number of thoughts, but let's start with the fellows and see what they have to say.
Anybody wants to try? Just from the basic, like you have this AKI patient.
I think Dr. Hamad was kind of hinting at it with the labs he was asking for, but TLS should be on there on the differential.
Yeah. You want Rexy to come up?
Anything else?
And obviously, guys, a measure of TLS would be looking at uric acid, phosphate level. We're dealing with lymphoma, so release of cells, dead cells into the circulation. That would be accompanied by elevation of LDH. So that's before you consider other potential causes of renal injury in somebody that is treated with this matrix combination chemotherapy, which includes what, Chris?
Yes. So actually, I'll get into exactly what the combination includes, but it's methotrexate based, high dose, includes some glucoverin. Yeah, TLS should definitely be on a differential. She wasn't. The other markers, the potassium was okay. The calcium was normal, but absolutely TLS on the differential.
Now,
sorry, what was the chemotherapy agent again?
It was a matrix. It was high dose methotrexate, leucovorin. Actually, I have it right here. It was the hyper CVAD. It's part B methotrexate plus cytarabine, or matrix chemotherapy.
that also includes thiotepa. Chris? In addition, it includes thiotepa, which is a cross-linker of DNA, and it essentially inhibits DNA synthesis, and as a result, inhibits proliferation.
I think with methotrexate, you can also see ATN. So kind of like thinking of in the rounds of Onconef, like a lot of these chemotherapy agents, like point inhibitors, you have to think about like adverse drug effects. So like I know that with methotrexate, you worry about ATN. Cytarabine, not so.
Thank you, Taki. So methotrexate can cause acute liver and kidney injury, ATN essentially. Cytarabine does something similar, and thiotepa would be expected to have synergistic effect with both methotrexate and cytarabine. So ATN is a possibility, but also consider the possibility of TIN, which many of these drugs can cause.
Yes, excellent. So, right. So she was started on high dose methotrexate and the cytarabine infusion with a leucovorin rescue. This is another recap of sort of the events. She finished her first cycle on the 27th February. Her methotrexate level at that time was 0.05 micromoles per liter. She was discharged. Came back on the 20th. She was started back on the second cycle on the 20th. Came back on the 18th. At that time, her methotrexate levels were 11. So the thought was that the picture was consistent more with methotrexate toxicity, renal toxicity. Any other thoughts on that?
Does she have liver injury as well?
Her liver profile was normal. AST, LT, and the bilies were within normal range.
You cannot blame it fully on the methotrexate, but you also had two additional agents which would definitely inhibit KILF, first of all, and inhibit proliferation of the proximal nephron cells, which are fast dividing, and the effect would be magnified in the presence of methotrexate, of course.
Mm-hmm. The cytarabine being the second agent.
And the thyrotepa.
Yes.
And Chris, how was TLS ruled out?
Honestly, I'm not sure. I think the other, just looking over the labs, she just didn't have the, like I said, the potassium was within a normal range, and so the calcium.
Yeah, Chris, the uric acid, I think was checked several times. It's always normal.
Yeah,
Okay.
it was 4.6.
And the phosphorus calcium is always in normal. So it's kind of ruled out in the beginning before we were consulted.
Sure.
Yes. Methotrexate is very commonly used in treating various types of cancers. It is renally excreted. 90% of it is renally excreted, and it can accumulate in the urine under conditions such as dehydration, or if the patient isn't appropriately prepped with an alkaline solution, then you can precipitate these methotrexate crystals, which can cause renal toxicity, renal damage, tubular injury. And this happens in about 2 to 12% of patients. And it mostly has to do with just the precipitation of the methotrexate crystals. Methotrexate itself is an anti-proliferative agent. It's an antifolate. It just inhibits DNA production of DNA. It targets the enzyme dihydrofolate reductase, and this basically just inhibits the reduction of folic acid.
Yeah, wake up. 6:20, yeah. I don't want to.
So the longer that you are exposed to the methotrexate infusion, the higher the likelihood that you'll experience renal toxicity. And this has to do with the polyglutamation of methotrexate, which leads to it staying intracellularly longer and having a longer effect.
Some bug has been biting my ear.
Again, methotrexate inhibits the hydrofolate reductase enzyme, and this has the effect of inhibiting DNA synthesis.
Oh my goodness.
This is a study out of India. Unfortunately, it's in a pediatric population, but it has some good information. They looked at 244 high-dose methotrexate infusions in 62 ALL patients. Out of the 244 cycles, the serum methotrexate levels in 35 of those cycles was greater than 1 micromole per liter. And out of the 35 cycles with a greater than 1 micromole per liter concentration level in the serum, 31 of those cases had renal toxicity. And there was a higher association with toxicity in the first cycle. and this basically just reiterates that there were 244 methotrexate infusions with 97 AKIs, and 31 out of the 35 patients with serum levels greater than 1 had an AKI. And the majority of the toxicity occurred in the first cycle of the therapy. So within the first 24 hours, the methotrexate levels can vary, but they're very high usually. That first methotrexate level should be drawn after the first 24 hours, within the first 24 to 48 hours to assess renal toxicity. And as the infusion progresses, the longer you are on the infusion, the lower the thresholds are for nephrotoxicity or toxicity in general. And this has to do with the polyglutination and the methotrexate being around longer within the cells, and the higher likelihood of it precipitating within the kidneys and causing other tissue damage. So usually it's the 24 and 48 hour mark where you want to look at the methotrexate levels. However, there is a study, and I wasn't able to find like an E version of this paper, but you can actually look at the methotrexate levels within like that first 24 hours, and the threshold is a little bit higher, and it goes kind of in line with the curve here. You have to be over 10 micromoles per liter, and of course, in the setting of an AKI with abnormal renal function, you would consider that methotrexate toxicity. So this is sort of where our patient falls into, because the level was drawn while the patient was receiving the infusion, like 24 hours into that infusion.
Yeah, I just the limit of that, it takes time for the methotrexate level to come back in the lab. The turnaround time is actually over 48 hours. So that can cause a delay in the diagnosis, but you need to have enough clinical suspicion when you see AKI after methotrexate infusion.
Mm-hmm. So the treatment options are mostly you have to just give IV fluids and pretty aggressively hydrate the patient with urinary alkalization to increase the solubility of the methotrexate. And then there is the leucovorin rescue, and basically leucovorin is it's a folic acid analog, which can be used, can bypass the dehydrofolate reductase step to replete the DNA synthesis precursors. Another option is glucoparidase. This is an enzyme that basically just breaks up the methotrexate before it enters the cell. There's some good evidence that it can be helpful. There's a couple studies I found. This one showed pretty promising results with 98% reduction in the plasma methotrexate within 15 minutes of administration. The only downside was that rebound was common. So a lot of the patients actually had a lot of rebound increase in methotrexate levels. This was just two case studies from Philadelphia showing CRT versus intermittent hemodialysis for methotrexate toxicity. CRT took a lot longer to bring the levels down. It took about 8 days for the levels to come down with CRT. Also in the setting of glucoparidase use. However, these particular patients were very resistant to the glucoparidase. Intermittent hemodialysis did a really good job of bringing down the methotrexate within just one session. Some agents that inhibit that can increase the methotrexate levels include nonsteroidals, Bactrim, penicillin-like drugs, PPIs, some antifungals, amphotericin, and then ACE inhibitors can also do that. And our patient wasn't on any of these medications. Any other questions?
So to update on the patient, this patient after we consult, and she is always seeing non-oliguric AKI. So she was started on the bicarbonate drips at about 200 cc per hour for several days, and her urine output was excellent, around 3 to 5 liters a day. So the goal is to keep her urine pH above 7.5. So her urine pH was always above, almost close to 8. And her AKI resolved gradually. Her methotrexate was stopped on day 1, but the level didn't come down until several days ago. The peak was around 11, and it dropped until less than 1. Then we stopped IV fluid and all the other supportive care, and she was discharged. I don't know the follow-up because she needs repeat cycles if hematology plan to give methotrexate again. But from literature, what I read is you can still dose methotrexate even they have the AKI episode in the past, based on the like case studies. So, but in this case, it's interesting. It's usually like you can see the jump of creatinine actually just a marker indicating it's a kind of not a good marker for our AKI. When you see renal function damage, it probably already happened before the creatinine starts to rise up, but we don't have good markers to detect the AKI in the early stage. So just have to keep the patient on the hydration and alkaline the urine. Any other thoughts?
Jane, did you guys check CK by chance?
Check what? Sorry, Dr. Ma.
Okay.
Sorry, I cannot hear you.
If you guys checked CPK, and the reason for my question, if you look at the jump of creatinine from almost what, from 0.6 or 0.7?
Yeah, 0.6 to 1.7.
To 1.7, normally, even renal shutdown, you get doubling of creatinine within the first 24 hours.
Mm-hmm.
You had here almost 3 times rise in creatinine, and one wonders whether there was some muscle injury at the same time contributing to the rapid rise in creatinine.
I don't remember. I can go back to check. Yeah, good point. Yeah, it's the jump is very significant.
Yeah, a huge jump, about 3 times the baseline, which is highly suspicious for muscle breakdown and increasing creatinine beyond what you would expect just based on complete shutdown of the kidney, which normally would raise the creatinine by a double in a day.
Any other thoughts? Any other comments?
Hey, Jane, can you hear me?
Oh, yeah, sure. Ashwin?
Hey, guys. Yeah, hey, Ashton, one of the older fellow graduates these days. I'm practicing out of Austin. One of my first times listening into your guys' conversation. I'll say this, I ran into a case a couple years ago of methotrexate-related toxicity, and doing some research, looked reasonable data stating that if you really flood patients prior to receiving their methotrexate dose with isotonic bicarb solution, and you get their pH around 8, even if you give them a metabolic alkalosis, iatrogenic alkalosis, they tend to have lower risks of forming crystallization and having I'll say this, posit another question to the presenter. If I'm taking care of a patient that has sarcoidosis and they're on 2nd line, 3rd line treatment with methotrexate weekly, or a rheumatoid arthritis patient on oral methotrexate, do I need to consider methotrexate toxicity? If so, why or why not?
So usually oral dosed methotrexate is a lower dosing. Renal toxicity is common once you overcome once you go above something like 30 micromolars. You would have to have a high infusion with a high dose methotrexate to overcome the solubility factor in within the tubules. I'm not sure if you could achieve that with an oral dose.
You're right. So that's absolutely correct, is that the intrathecal infusions for treating lymphomas are very high dose compared to any oral regimen that you can take. Usually if patients are taking oral methotrexate and they achieve maybe an overdose, you're definitely going to see a bump in liver function tests and CBCs. One thing I also mentioned on the differential that any patient should have when they're receiving chemotherapy is a TMA type injury. A lot of these newer chemo agents, including the old school agents, can be associated with TMA injuries. So always have that on the differential.
Thank you, Ashwin. You obviously haven't lost your sharpness.
Thank you, Ashland. That's a very good point.
I would like to add just a point on that oral dosing, because I ran into one of the cases myself who was CKD and rheumatoid arthritis with treated with methotrexate. She also, my patient was diabetic, and as her renal function declined, rheumatology did not adjust the methotrexate dosing for her renal function. So she presented with bad toxicity even with oral dosing, because she continued on a higher dose even though her renal function was persistently declining. So something to keep in mind. Sometimes just a normal dosing for someone with several other comorbidities, even oral, can be bad.
Rita, do you reduce the dose or you just stop the methotrexate completely?
So it has to, I mean, it has to be proportionately reduced. Like there is a whole, like, creatinine clearance based adjustments. And once it drops below 30, then you have to, look for alternative for DMARDs rather than continue. That's the recommendation. So in this particular patient, we ended up switching the therapy because she was toxic and basically it was far gone at that time.
But if you have a new patient never on methotrexate with CKD3, would you start would you choose this as an option or no?
Probably not, because I mean, the dosing says not to be used, like, or those CKD3, yes, you can, like CKD3A, you can use like 65%, it says, or 50%. But CKD4 and above, you wouldn't, probably.
Okay. Thank you. All right. Thank you all for the experience to share. All right.
And good job, Chris.
Yeah, good job, Chris. Thank you.
Thank you.
Questions, we'll move to the next case. You can stop sharing, Chris. Okay, next case is by Dr. Edgemore, metabolic alkalosis case. Suleiman, are you able to share? FYI, I'm recording this conference. This is the first time doing this today, just to share if somebody wants to review and miss the meeting and they have a chance to join. I hope everybody fine with my recording. Good.
You guys can see the screen, right?
Yeah, very good.
Okay, good. So let me start. My name is Suleiman Ajmal, one of the nephrology attendings here at St. Luke Hospital. So this case is from, let me see if I can move this. So how do I actually, it doesn't move. Why is that? Did I get into this problem? I think the last time as well when I presented it. Okay, good. So this case is from Texas Children. So we have a 30-year-old patient, known history of Duchenne muscular dystrophy, chronic respiratory failure, status post tracheostomy a few years back, chronically on vent, has a gastrojejunostomy tube, and has all been taken care of by his mother, who is very involved in his care. And she brought the patient to the hospital saying that the patient is not acting like himself, not as active or emotive for the last 2 days. So for a mother, patient able to communicate basic needs to her at baseline, otherwise, so is awake and talk, say a few words when they, probably when they cap the trach at times. But since last 2 days, he's been more drowsy and almost nonverbal. So otherwise, there was no reports of fever, chills, no cough, no neck stiffness, no abdominal pain or dysuria for a mother. So past history, as I mentioned, so Duchenne dystrophy, there's genetic cardiomyopathy associated with that. And his EF was previously low, but recently the EF was fine for the most recent echo. And then he has restrictive lung disease due to scoliosis and vent-dependent respiratory failure, status post trach since 2012. Then gastric dysmobility in GERD, and he had a GJ tube placed in 2012, and baseline creatinine was around 0.7 to 1.1 per old records. Current medications, just he gets some multivitamins, albuterol, NABs, folic acid, carvedilol, Protonix, Carafate, and he was on enalapril but was stopped due to hypertension more than a year ago. And then he was recently started on some Lasix 20 milligram daily. They started 2 weeks ago because his magnesium was high. I mean, he has a home, he has a home health nurse that comes, and because he gets all these tube feeds, they monitor some of the electrolytes periodically. And then his enteral feed formula is he gets Nutrien 1 can with 120 cc free water 4 times per day. So exam, the initial exam, he was tachycardic 225, he was afebrile, and he's on vent with FiO to 40% and respiratory rate was 16. SATs were okay. He was otherwise chronically ill appearing guy. He was awake though, and he mumbles. And then his oral mucosa was dry, but then he doesn't eat anything through mouth anyways. He was tachycardic. Otherwise, there was no murmurs. Lungs appeared clear to sounded clear on auscultation. Abdomen was mildly distended. There was this gastrojejunostomy tube present, which is basically biluminal. So it has like 2 lumens. One is for suction, and the other is to give the food in. Skin clear, and then extremities, there was chronic deformity in at least +1 edema in his legs, and also the feet was sort of deformed as well. And then initial labs, I think the reason they consulted us, so he has a white cell count of 18.7. His hemoglobin, he was anemic to 9.8. Sodium was what, 47. Potassium initially was 4.1. Then the repeat in a couple of hours was down to 2.7. Then he had a chloride of 53 and bicarbonate of 64. His BUN was elevated to 266. Creatinine was 2.47. Calcium is 10.5. Phos is 7.8. Mag 3.8. And his pH was at like 7.81 with a PCO2 of 53. And then they also check his cystatin C, which was 11, and glucose was 190. So, I mean, I would just ask a few, one of our fellows, what do you think based upon the initial labs here, what do you think is the issue here? What sort of acid-base disorder do we have, and what's causing that along with the AKI?
You have a, this is the key. So, I mean, you have a very profound, a hypochloremic metabolic acidosis, alkalosis, excuse me, hypokalemic as well. The thing that really stuck out from the history was that the new initiation of a diuretic, so you worry about a contraction alkalosis. If he's on a TPN, you would worry about not only the protein content, but also the amount of citrate or acetate in
He's
the
on
feed.
enteral feeding, right? So he's on the J2 feeding.
Oh, okay.
So he was getting the nutrient along with the free water.
Yeah. So those are the two things I would be worried about in terms of what driving the metabolic alkalosis is the things that I just mentioned.
Right. So you think it's probably either contraction alkalosis but then the AKI most of the time associated with acidosis, right? So here I think what do you think about that? Do you think that renal failure has anything to do with the alkalosis?
Probably not. No, I wouldn't think so. No.
Okay. All right. Let me show. I mean, a couple of other slides. So urine studies. I mean, the pH was alkaline to 9, protein 3+, and then these are some of the urine electrolytes, which you can see, and a few more things. So on chest X-ray, he had stable cardiomegaly, and then there was some pulmonary congestion. Ultrasound, he had a pretty small size kidneys. There was 6 centimeter and 8 centimeter with diffuse leucogenic parenchyma, and then they were profoundly decreased as compared to from previous ultrasound that was 10 years ago, and there was no hydronephrosis. Okay, so I think the question is what's the etiology of AKI, what is the acid-base disorder, and what caused the acid-base disorder, what is the precipitating factor, and what are the maintenance factors? So Taki, you said that AKI is because of, you said Lasix?
Yeah, maybe intravascular depletion.
But just like 20 milligram of Lasix, that's it?
Yeah.
Causing that profound problem?
Yeah.
And then, okay, what's the acid-base disorder? What do you think? I mean, so the pH is 7.81. I mean, because I think me and the ICU attending, we were sort of like astonished. We never saw that high pH. So that was probably, I mean, what do you think is contributing to this sort of profound alkalosis?
Are attendings allowed to pitch in?
Yeah, sure. Please go ahead.
So can I help you, Taki? So first of all, this patient, based on the kidney size, has end-stage renal disease. The fact that the creatinine was low, based on what the creatinine normal values, it is misleading. And obviously, this patient has very small muscle mass in spite of his weight. What was it, Suleiman? 50 something?
Yes, I think I was. Yeah,
probably fluid in the large part of it. So this guy has essentially end-stage kidney failure with shrunken kidneys.
Right.
And these kidneys would not have shrunken overnight in the process of developing an acute kidney injury. So that's number one. Number two, so he's making urine, but essentially has no clearance. So you have to consider this patient as end-stage kidney failure to begin with. He's making some urine, but it is pretty much just water without any clearance of toxins. That's number one. Number two, this patient is on vent and has restrictive lung disease. So at baseline, he has respiratory acidosis.
Right.
And expect the compensation from whatever the kidney function can do or whatever those kidneys can do, you would expect to have essentially elevated bicarbonate as part of the compensation for the respiratory acidosis. Number three, now you add a component of diuretics, which will lead to contraction alkalosis. Having said all of that, none of this would have caused this elevation of bicarbonate. There must have been some other process and some problem with his JG tube where he probably has high residual or high gastric lavage from that tube that is essentially causing loss of acid. And my suspicion that the carotid that the patient was receiving in high dose was causing biswar somewhere, causing obstruction in his GI tract. Any of this, Suleiman?
No, so I think superb ideas. I think some of them are correct. I think this guy is pretty fascinating. I'll show you the case. The only thing as far as just at the interpretation of ABG, I mean, I don't know. So here's the deal. So this guy is on a vent and his vent settings are fixed. So I think what my interpretation of the initial VBG is that if you look at the pH, so you have a bicarb of 64, and so it's a metabolic alkalosis. So your compensation is going to be that you need to blow out more bicarbonate. So normally the correction is 0.7 of bicarb would lead to increase or decrease of increase of PCO2 by 1. So he is actually hyperventilating because of the vent problem. So I will show that as well. So I think that's what I thought, that the guy is supposed to be, he should have a compensatory respiratory acidosis, but he's not able to do that because of his high respiratory rate on the vent. So ideally his PCO2 should have been like 70 or 80, and that would have compensated the pH. So that's another contributing factor to the alkalosis, because the guy is not able to compensate.
Yeah, but that would make him stop breathing.
Well, but here's the thing. So if he was breathing at 16 on the vent, he, in a normal circumstances, he may be breathing like at 10 or 12 if this would have been his natural breathing. So I thought, at least that's what we thought, this could be one of the contributing factors. So anyways, I think let's
but was there also a component of respiratory acidosis on a chronic basis?
Well, no, because the guy has been on a vent for a very long period of time with stable respiratory rate. So, I mean, that's what they adjust. So, I mean, if he's getting a 16 breaths per minute.
Yes, from before, Suleiman?
So I think previous ones were all slightly on the alkalotic side, but nothing that crazy. So 7.4 was around his baseline.
What was the PCO2?
They were in the, I don't exactly remember the PCO2 right now. No, I don't think I remember that.
So what you're suggesting is there may not have been a component of respiratory acidosis on a chronic basis.
Right, no.
Though he had restrictive lung disease.
Yes.
And Duchenne muscular dystrophy.
Right.
Okay. So I agree with you 100%. So because of the metabolic alkalosis, the compensation would have been to retain CO2,
sure,
but he's unable to do so because of the fixed vent setting.
All right.
But primarily, Suleiman, you would not develop such a severe metabolic alkalosis without losing acid somewhere.
No, exactly. So I think let me go over that. So the initial thoughts which I had, or after long discussion with the ICU attending over there, we thought, okay, what's the initiating factor for alkalosis? Obviously, there's volume depletion from oral Lasix. You probably would be getting high protein tube feeds, maybe less free water intake. And there could be loss of gastric acid secretions through the GJ tube. And then what are the maintenance factors? Probably hypovolemia. Then AKI itself is very related to metabolic alkalosis, because obviously you have to lose a bicarb through the kidneys, and if you have AKI or renal dysfunction, you won't be able to lose the bicarbonate. And then hypokalemia also contributed, and then lack of respiratory compensation due to a vent-dependent state. So these were, at least this was the basic hypothesis to go. And then obviously based on the kidney size, we were all thinking, okay, I mean, what if this guy could be like advanced CKD or but this was something new as well, the kidney size problem. So initial recommendations were obviously start with some volume replacement with some normal saline, 100 cc per hour, and then potassium replacement, consider some Diamox because of his cardiomyopathy, and there's already some edema present in the extremities and tenuous respiratory status, and then decrease the minute ventilation to allow compensatory hypocapnia, and then PPI to suppress gastric acid secretion, and then otherwise sepsis workup and monitor electrolytes and check a PTH level. Those were that was the initial plan. And then let's see what happens here next. So again, I think, sure.
Was there a problem with the GJ tube? Was he losing acid somehow?
So I think that's what we wanted to monitor. Initially, there was no report of that, but I think they said that he has increased secretions through there as well. but it was not like a major problem or major report on the initial, when we were initially evaluating him.
Did you ask the mother?
Yes, I think I did ask the mother, and then they did report that he would have secretions here and there, but they said they were going to attach that GJ tube one port to the suction and then see how much we are able to drain.
Suleiman, another question is if the tube feeding, either bicarbonate or citrate, do we know the formulation there?
So I think I tried to look up nutrient, but I think it was primarily all bicarbonate in there.
Bicarbonate there?
If you look at the...
I'm curious to know how much, like maybe the alkaline in the supplements on the in the feeding, yeah.
So that's actually...
I'm not sure if it will be a case, or this is, like Dr. Haman said, it's very likely this is a GI loss, most likely. But the history is just interesting if there's no obvious history.
Yeah, Suleiman, for this degree of metabolic alkalosis to develop,
right,
there is pretty much only one pathophysiology.
Exactly.
And that is loss of gastric acid.
Sure. No, I think, I definitely agree on that with you. So let me just show you the case otherwise. So I think in the end, I think the ICU team was putting all the orders. So they started with D5NS with 20 of KC at 100 cc per hour. They also started Diamox 250 cc IV for 6 hours. All right. Day number 2, the guy became a little significantly hyponatremic, 162. His BUN was 191, creatinine 2.47. Calcium was also slightly elevated at 10.8, although the ionized calcium was fine. Now the PTH came out to be superbly high at 1446. And then the pH did improve somewhat with fluids to 7.65. PCO2 is now 62, so we did decrease the setting a little bit. Now his urine output is been 2.4 liters, and then he did actually drain 760 cc output from the GJ tube. So definitely there was increased output from the gastrojejunostomy tube as well. So based upon this, now the PTH was high. I think we even did put him on a low dose of Sensipar. Even until at this point, we were thinking that, yeah, this guy is pretty much like a advanced CKD patient based on the kidney ultrasound and all these findings. Then I think
how long ago was the creatinine of 0 point something and 1?
Just like a month ago.
Okay.
So this was all pretty acute.
These kidneys could not have shrunk to this size in such a short period of time.
I know.
This guy has essentially end-stage kidney failure for a while.
No, I think, I definitely totally agree. I think that's what we thought as well. So that's day 2. Then at that point, we did change the fluids to hypotonic. We did started some free water through the GJ tube, 50 cc per hour. And then the tube fees were changed to Suplena, which is more renal friendly. I think that's probably what the TCH has it available. And then we generally targeted to keep him at least net positive by 1 liter. So just give him some more fluid. And then we also started him on Epogen because of severe anemia. Hemoglobin down was 6.6. Day 3. Now, when you look at day 3, I think that now things are much better. Now the creatinine is even down to 1.25, hyponatremic still 149, pH is down to 7.5. And again, urine output is 2.2. At this point, we did increase his free water even further. The ICU team really did not want it to give too much fluids, but overall, we continued the half NS at 100 cc per hour as well. So, things did improve for him quite a bit. And then by day 5, you had a creatinine down to 0.75, FOS down to 5.5. I think at some point we started Sensipar, then even stopped it. And then I think when I signed out, one of my other colleagues thought that he probably could have like primary hyperparathyroidism because the PTH was just inappropriately high in setting of this creatinine. So K 3.1, and then pH is pretty much normalized. Now, after this guy stayed in the hospital for a few days, and then the mother wanted to follow up with me in the clinic. Anyways, they discharged him home with Suplena can with 120 cc free water 5 times per day, plus additional 1 liter free water, and then potassium supplementation as well. So I saw him 5 days after discharge in the clinic. Now the guy is becoming more hyponatremic, 133, K is down to 2.0. Bicarb is again up more than 40. So we advised him to decrease the free water. We repeated the labs, but I think he became more hyponatremic to 125, and then he got readmitted. Interestingly, when I looked at the lab, now this time I was not on service, but I reviewed the chart, his pH again was up to 7.8. And I think that's where the whole thing came, that no one changed the jejunostomy tube at that point. So I think that's how we have to admire Dr. Hamad, that he came up with the right diagnosis right away. So then the creatinine was 1.25 at that admission. They increased to 0.3 to 0.5 range within one day of IV fluids. Cystatin C was although still slightly elevated. I don't know how to correlate that well, because I don't think there's any standardization, or we don't use it in our other hospitals. And then again, they reported high GJ tube drainage. They switched him to TPN, and they finally exchanged the GJ tube. And with that, I think since then, the numbers have been pretty good. And at least there is no, the alkalosis is improved. Most recent pH was 7.4. I think the guy is still in the hospital for other reasons. And then we actually changed the tube feed back to nutrients, so non-renal diet, because of persistent low K and FOS, and then obviously free water adjustment. So I think the metabolic alkalosis was primarily from the GJ tube, but I think still the issue remains that did this guy had CKD, or what's the extent of CKD, I still do not know, because now the creatinine is actually 0.3 right now if he's in the hospital. The cystatin C is still borderline elevated, and then what to do with the PTH, I mean, we'll see.
I think creatinine is a marker for his kidney function. It's not a marker.
Right. But I mean, it did change quite a bit. So it went up to 2.7 at one point, and now it's down to like really 0.3. So
keep in mind, this guy does not have much muscle mass.
Yeah.
Sure.
And I believe the kidney size on ultrasound.
Sure.
With this size shrunken kidneys, you basically don't have much kidney function left there.
Right.
So obviously, this guy doesn't really have much muscle mass.
Sure.
All he has is probably just edema.
Right. No, I agree. I think that's what we counsel. Yes, sir.
Do you have a cystatin C when everything stabilized, and you said when his creatinine was less than 0.3?
Yeah, so I think the most recent is 2.9. So I think that's what 2.9 was probably when the creatinine was 0.3.
Okay.
Guys, I don't think that the cystatin C is of any use in this case. Keep in mind the cystatin C comes from any cell and any tissue. And this guy's organs and tissues, specifically muscle, doesn't exist. So it's elevated cystatin C, but it might not be what you would expect for the degree of renal failure.
Right. So yeah, I mean, I think that's what I have for this case. And but I thought this case was interesting because probably the metabolic alkalosis in his case was probably the combination of almost all the factors which I read in the book, and probably he almost had all the maintenance factors as well, which sort of like led to this sort of alkalosis. Although I agree that without the GJ tube drainage, you cannot achieve a pH as high as this. So just
additional suggestion as well.
Yeah, go ahead, sir.
The carafate in this patient is extremely high dose, and carafate might produce bisoires. So you may want to image the GI tract with a barium follow-through to see if he has any of these obstructing flow in the GI tract.
So this outstanding case, this fluctuation of the numbers, the changing the speed is really amazing. I think a lot of learning points there.
Right. No, I think it was a really
summary
cool case.
Of this case. This is very nice.
Yeah, sure. So
and,
I think now
this is the highest number we have ever seen.
Yeah, I think that's what the ICU team over there also thought, because everyone was just surprised and how can you achieve this sort of alkalosis? But really, I think he had all these combination factors.
You know, in Chicago, the Rush University, the professor, Dr. Robbie, is collecting all these extreme numbers, like bicarbonate, your pH. So I will definitely send this case to him and get his experience, maybe get something published.
Sure, yeah, I think we will definitely work on that.
Yeah.
Sure.
Yeah, this is very good.
Did you guys consider giving hydrochloric acid? I know some UT faculty, they like giving it every once in a while.
Well, I think there was a there was a discussion, but then I think because he improved quite a bit with the fluids, so I think then we did not pursue with that. But initially, we were thinking about all these options, also including dialysis as well.
Yeah.
Thank you,
You can also give ammonium chloride.
Exactly. Ammonium chloride would have also been as effective because ammonium chloride is a weak acid. But you could have solved all of these problems within a day with dialysis.
Well, but I think in the end, if you can avoid dialysis, I mean, the guy's already going through quite a bit. His mother was really concerned. And I think if you can just manage it on the other, just with fluids, I think that the GJ tube drainage was probably delayed. I think this should have been done on the first admission, which I think probably led to his second admission as well. But otherwise, I mean,
yeah.
I mean, I don't know.
You already did a very amazing job, Suleiman. Oh, I'm curious about the calcium issue. So have you repeated the PTH and the calcium level after his more volume repeated?
So I think we have not, well, I know, I think right now, his ionized calcium has almost always been normal. Okay. And then on this repeat admission also, it was normal. I did not add some of those labs because that would have been too much, but they are actually, we have not repeated the PTH though, but the calcium is actually in normal range right now.
Okay, I'm just curious if he could have primary hyperparathyroidism, which will dispose him to the volume depletion status.
Well, I think that's true because I initially started the Sensipar, but then he had to stop it because really the calcium was actually getting slightly on the lower side. So then he didn't go home with that. And I think the next time also they didn't start it yet, but we'll figure out repeat as an outpatient. Yeah. All right, guys. So I think I'm just a few slides on metabolic alkalosis. I think I just really like this topic. So I just put some basic slides for the fellows as well. So generally, obviously, it's a primary increase in serum bicarbonate concentration due to either loss of hydrogen ion or gain of bicarbonate. So always in pathogenesis, you're going to have a generation or the induction etiology, and then they need to have a maintenance factors as well. So induction, you have essentially like 4 to 5 causes. Either you're going to ingest alkali, or you're going to have a cellular shift, or you can lose acid either in GI tract or renal losses, or you can have contraction alkalosis. And these are just like some of the basic etiologies. So GI losses either could be mostly an upper GI loss because that's where all the hydrochloric acid is. And then lower GI losses where you have chloride-rich diarrhea, either in the form of laxatives or chlorhydria from villus adenoma. And then the renal losses are actually much more interesting. And I'll go over some of those, including the hyperaldosteronism and duplithiazide diuretic use, Barter's and Gitelman syndrome, and then some milk alkali and post-hypercapnia. Or you can just have a hydrogen shift, which mostly happens in hypokalemia, or you can have alkali administration, which is either in TPN, you can take acetate or citrate, which we give during, as an anticoagulant, or you can take antacids. So just I'm going to talk quickly about some of these renal causes. So like hyperaldosteronism, I think I like some of these slides, which are pretty useful for the fellows. If you have hypertension and hypokalemic metabolic alkalosis, you're going to look for aldosterone level. And then really that's going to drive your show. If it's high, then you look at the renin. If renin and aldo both are high, you're looking at either renal artery stenosis or malignant hypertension or reninoma. If the renin is low, then you're looking at primary hyperaldosteronism or GRA. And if the aldosterone is low, but you have a picture similar, like a pseudo-aldosteronism like picture, then you're either looking at Cushing's or Liddell's or licorice or SAME, which is the syndrome of apparent mineralocorticoid excess. And then these are the testing which we can do. Obviously, if you have renal artery stenosis, you can do either MRA, Doppler, or a captopelvineal scan. For primary hyperaldo, you can do an aldo to renin ratio. And then for Cushing, you can check serum to urine cortisol, and Liddell's, you can do an ENaC mutation analysis. If you have a syndrome of apparent mineralocorticoid excess, you do a free cortisol to cortisone ratio. And for GRA, you check for urine 18-OX3 and hydroxycortisol levels. These are some of the workup for the hyperaldosteronism related metabolic alkalosis. And then just quickly on a few slide on milk alkali syndrome, that Basically, it's a combination of AKI, hypercalcemia, and metabolic alkalosis. And now it's most commonly occurring because of calcium bicarbonate absorption. So its mechanism is interesting because you need an alkali and calcium load both. And then alkalosis will lead to increased calcium reabsorption in the distal collecting tubule and decreased excretion. And then calcium itself will lead to natriuresis and decreased hydrogen excretion. And then obviously calcium would cause vasoconstriction leading to an AKI. So this just like a combination of all these things lead to the milk alkali syndrome with metabolic alkalosis and an AKI picture. And then it's post-hypercapnic alkalosis. So this can happen due to chronic CO2 retention. And then you're going to have a compensatory renal bicarbonate retention. And then obviously you put them on mechanical ventilation. This leads to a rapid correction of the PCO2, but the bicarbonate would stay elevated. Now, kidneys can excrete, again, get rid of this bicarbonate if there's sufficient time and adequate renal function and euvolemia. If those things are not there, you can have a post-hypercapnic alkalosis. And then just the mechanism of hypokalemia induced metabolic alkalosis. So the shift happens intracellularly, so hydrogen ions move in and potassium moves out. And then the other thing is that there's also an increased activity of hydrogen potassium ATPase in the medullary collecting duct, and that also would lead to a loss of hydrogen ions. So lead to metabolic alkalosis as well. And then just for a contraction alkalosis, which is also now called as chloride depletion alkalosis. So basically you're going to lose chloride and water in excess of bicarbonate. And then this leads to failure of renal bicarbonate excretion. And basically three things will happen. So, one, you'll have increased proximal tubular sodium reabsorption with bicarbonate. There will be increased aldosterone, and then there will decrease activity of pendrin. So there will be decreased bicarbonate excretion as well. So overall, it will just lead to accumulation of bicarbonate. And obviously alkalosis, we have to give fluid to improve this. And then as we talk about some induction factor for alkalosis, there's always have to be some maintenance factors. Most of the important maintenance factor would be the reduced effective arterial blood volume. And then hypokalemia, hypochloremia, renal failure, and hyperaldosteronism. So all these factors are maintenance. So I think the initial question I mentioned that if the AKI has to do anything with alkalosis, so it is very important because if the kidneys are not working, you're not going to get rid of that bicarbonate. And then for management, generally, obviously, simple history, upper and lower GI losses, diuretic use, renal disease, bicarbonate ingestion, including antacid, milk intake, fatigue or muscle cramp. All these questions could be helpful. Exam-wise, you're going to do vital signs, volume status, cardiac auscultation, dental and skin changes. And then investigation, you do your basic blood work, EBG, urine chloride. And then these now for diagnosis, there are two things going to be important. One thing is obviously your volume status, and the other is the urine chloride, which is going to be very helpful. So if the urine chloride is low and you're normotensive or volume down, you know this is either vomiting or GI related loss or prior diuretic use or post-hypercapnia. If there's hypertension and chloride is low, then you're looking at Liddle syndrome. And then if your urine chloride is high, and then you're still normotensive or hypotensive, so you're either looking at magnesium or potassium deficiency or Bartter or Gitelman syndrome or acute diuretic use. And then the fourth one is when you have high chloride and you're hypertensive, that's where you're looking at renal loss of, including the primary hyperaldosteronism, renal artery stenosis, or renal failure with alkali therapy. And then this was a slide which was pretty important. I think I like it for the boards as well. There are time-dependent changes in the urine electrolytes. So you see that if someone's vomiting or having GI loss, initially there will be low chloride, but the sodium will be high because they're trying to get rid of the sodium along with the bicarbonate to maintain the pH. So the pH will be alkaline. But in later stage, once you develop volume depletion, then at that time, the urine sodium will be low, bicarbonate will be low, chloride will be low, and you have a paradoxical aciduria. So the key is that in metabolic alkalosis workup, the urine chloride is probably the most important clue for the volume status. And then management, obviously you want to treat the underlying cause and correct the potassium and chloride deficits, correct the volume, acetozolamide in edematous state, and obviously consider dialysis and hydrochloric acid. Now for the other types, which is related to the saline resistant or the hyperaldosteronism related states, you can treat the underlying cause. And if you have primary hyperaldo, you're going to use aldactone. If you have Liddle syndrome, you're going to use amiloride. Or if you have something like GRA, then you're going to use glucocorticoids. And then obviously you guys can read more about it. And yeah, thank you very much.
Excellent. Thank you so much. I really like your table of the chloride, the early and the late stage of the vomiting, how the urine lights change.
Yeah.
Very, very good.
No, thank you. Thank you.
Yeah, it was
so
really
much.
fascinating case. Good job.
Fascinating.
All right. Thank you.
Any comments from the audience? All right. Okay. So this conference is recorded, and later I will upload. If you have any concern or question, just reach out to me.
Sure.
Thank you for Chris and this fantastic metabolic alkalosis case. Too good.
All right. Thank you very much.
I see you in June. Okay. Next one will be the last one in this physical year in June. Then we will start the new year. Thank you, everyone. Let me know if, as always, I want to hear more inputs and feedback from you. Have a very good evening. Appreciate it. Bye-bye.